Hi everyone, this is Soheila Rostami. I'm an oculofacial plastic surgeon, double board certified. Today I want to talk to you about upper eyelid and how you can tell what's going on with your eyelids or your eyebrows. So then there won't be any confusion when you come in considering having anything related to your eyelids, upper eyelids. We're not talking about the lower, but we're talking about the upper eyelid and the eyebrow and the relationship between the two today. So then it would be very clear for you if you do have any issues and what is related to. Okay, we're gonna start. So when we're talking about the upper eyelid, is the skin that starts from the lashes all the way to the border here. So your eyelid crease is included as well, but you notice that the skin quality changes at some point, and that becomes your eyebrow. So it's the mixture between the eyelid skin and the eyebrow skin. The eyebrow skin starts somewhere in relative to your eyelid on top, between the hairs on the eyebrow and the thicker skin quality that is right below the eyebrow hairline. So there is a relationship between the eyelid and the eyebrow. So that's why these two, because there is no real separation, are considered together. So that's why we cannot really tell you where the eyelid skin finishes and when the eyebrow skin starts. The only difference is the quality and thickness of the skin. So the eyelid skin is the thinnest skin in your body. It's only 1 millimeter, but the eyebrow skin, it becomes the normal skin that we have all over the skin of our face. So the thickness changes and it increases. So that's the only differences. Now, where the eyebrow sits is also ethnic related. So different race and ethnics have different set for their eyebrows. Also, gender differences. Female and male eyebrows are different. They sit in a different way, and that's how we feminize someone or masculinize someone, by changing their eyebrow shape and where it sits. Usually, female eyebrow has a lateral flare and it has an arch to it. That's how you feminize someone. And the male eyebrow is usually more of a straight line. Now, where the position is sitting is also different. The eyebrow in male is lower than the eyebrow in female. The eyebrow in male usually sits about 2 to 3 millimeter high above the orbital rim. The bone here, we call it orbital rim. That bony structure here is called orbital rim. And that, the eyebrow sits about a few millimeter above the orbital rim in male in a straight fashion. In female, it's about 7 to 10 millimeter above the orbital rim and in an arch form or arch shape fashion. So those are typical differences between female and male eyebrow differences. But as I mentioned to you, ethnicity comes into picture, and the Asian eyebrow is different than Caucasian eyebrow. And so these are all, you have to talk to your patient, or you have to know what the desire of the individual is to perform the best results for the patient. So these are very important prior to evaluating and discussing things with the patient. So now I want to talk to you about eyebrow ptosis and eyelid ptosis. They're totally different. One is related to the eyelid and one is related to the eyebrow. So we're going to start with the eyebrow. So this is the schematic presentation for the eyebrow. So when we're talking about the eyebrow being in a good position, it's right here. You can see the arch is there, and the orbital rim, and this is about 10 millimeter difference. And that's a female, very nice female eyebrow. Now, if you look at this, let me look at it. There is a eyelid ptosis on this photo. So if you look at it, the eye does not open as much as this eye. So what she's doing to be able to help herself to see, she's bringing the eyebrow on this side higher than that one. So it gives an appearance that the eyebrow is lower on this side. So sometimes the patient thinks that they have ptosis of the eyebrow on this side, but actually it's that they lifting this eyebrow. So the difference is because of the eyelid where it's sitting. So for them to be able to see, they lift the eyebrow to bring the eyelid up. Now, what's the true eyebrow ptosis? So this is a true eyebrow ptosis. As you can see, the eyebrow here is sitting nicely about 10 millimeter above the orbital rim. But if you look here, you can see that the distance from the eyelashes to the eyebrow is much lower than the distance from the eyelashes to the eyebrow on that side. So this is a true eyebrow ptosis or droopy eyebrow. So there's other pictures here. This is, and I like that picture to show you. This picture, as you can see, this eyebrow is too archy. They call it a Spock eyebrow when we do Botox. So they brought this eyebrow with the Botox higher on this side compared to this side. So this is an easy fix. So you just have to put a couple of units of Botox, disproportionate or neuromodulators on this side to even the eyebrows together. So this is more related to the treatment patient got. Now, as we were discussing, now if you look at this picture is showing you, this picture, again, it's very similar to this picture. The patient has a little bit of a droopiness and ptosis of the eyelid, and the patient is holding the eyebrow up, but also is a redundant skin on this side that causes the patient lifting the eyebrow. So as we get older, because we get a lot of redundant skin, like the picture on this side shows, our eyebrow position changes. We lift our eyebrow to be able to see. So a lot of elderly, they're doing this all the time. So that tells you that they need to have something related to the eyelid. Either they have ptosis, which means the true eyelid droopiness, that's the eyelid ptosis, or they have too much redundant skin that they're holding the eyelid up to be able to see. So what happens a lot of times as we get older and we're getting our neurotoxins, Botox, disproportionate, and the rest, we notice that we're not happy as we were younger. Why? Because the neurotoxin causes us not to be able to lift our eyebrows. Not that it's causing eyebrow ptosis or eyelid ptosis, but causes us to see that excess skin not be able to lift and is interfering with our vision. And that is the unhappiness that we get from the neurotoxin as we get older. So what happens, either you need to have the eyelid surgery, or you should have stopped getting any neurotoxins in your forehead until you're ready to get the eyelid surgery. Eyelid surgery for many patients is necessity at some point. And that's the reason insurances will cover it when it's interfering in a special level of your field of vision. We need our field of vision to be able to drive appropriately, to not to run into things. So that's the reason it becomes medically necessary. surgery. So it's because it interferes with your field of vision. And the same thing goes when you are doing it for cosmetic reason. So when you're getting, patients are having heavy eyelids, they don't like the appearance of it because it's a lot of redundant skin. And when they do their neurotoxin, they feel that heaviness and they don't like it. So those are the different reasons when you have redundant skin, you need to have the surgery. Now, ptosis repair and blepharoplasty are two different surgeries. We correct the droopy eyelid in a different method than the majority of cosmetic surgeries are done for redundant skin, and that is called upper eyelid blepharoplasty. And we take some fat sometimes or reposition fat. Even in upper eyelid, we do reposition the fat as well to show that is when we lose fat, especially the subbrow fat pad gives us a superior sulcus deformity. These are a little bit complicated, more advanced blepharoplasties done by oculofacial plastic surgeons. So even though upper eyelid blepharoplasty is for repairing of the excess skin and redundant skin and is a simple procedure, yes, it can be a complicated procedure as well, depends on what the assessment we do for the patient and what are our findings. So as you can see, I may find you have eyebrow ptosis at the same time. I can find that you have eyelid ptosis at the same time. And there is another problem, it's called superior sulcus deformity at the same time. So when you come in and you want to have eyelid evaluation, remember these things. I may talk to you about different procedures that you may need to get the ideal and back to regular position that your eyelids were when you were younger. So I really like for you to bring your pictures at the time or your consultations, so I can review all of that, see where your eyelids were sitting, see where your eyebrows were sitting, if you did have congenital ptosis when you were younger. So this is as a child, you could have a congenital ptosis, and as an adult, you could have the same thing. So these are different eyes. This is a child eyes, and this is an adult eye, and then you could have, as a child, you could have a congenital ptosis, and it could be bilateral. So these pictures, for you to be able to recognize the difference, is only one eye, but you could have, and majority are bilateral, and so you could have a congenital bilateral ptosis, and a lot of people do have a little bit of a ptosis compared to the norm as they are born or as they grow up, and that's normal. A slight asymmetry is not an unusual thing to see with the eyes. So a lot of times I may tell you, you see that there is a difference between the two eyes, which you never noticed before, but I have to bring it to your attention, because afterward you may notice it, because we keep looking at ourselves and we never looked at ourselves that critically. So we may notice it, and then I would say, yeah, I mentioned that to you prior to the surgery, and that's why I brought it up to you. So a lot of times those really don't need to be repaired if it's minor. If it's less than 1 millimeter differences, we usually don't touch them and we don't do anything about it, whether it is eyebrow, whether it is eyelid. So we really don't address the ptosis if it's less than 1 millimeter. I hope this clarifies a lot of your questions related to the upper eyelid and eyebrow. Thank you.